We're going to use this video to go over the quality codes that's going to be used for Hello Smile clinical team assessment. So in doing any sort of clinical treatment, it's always a bit questionable as to what is the best quality that's being provided by the clinical team to a patient. And of course, every doctor is a little bit different, and every team with their doctor may provide care that's a little bit different than another team and another doctor. And defining quality can be sometimes difficult. At Hello Smile, our goal is to make sure that we have a calibrated system across all of our doctors and all of our clinical teams and all of our locations where we all agree on some minimal quality criteria for every patient interaction, every patient treatment and diagnosis that we provide. Now, we have gone to the Institute of Medicine's guidelines for definition of quality. Institute of Medicine is an organization that studies all areas of healthcare and medicine, and they've studied quality, and they've come up with 6 criteria that define quality. And we have gone to each one of those criteria, and we have picked some representations of how they correspond to providing quality treatment in pediatric dentistry. And we have put them together in this document, and we have codified them. And by doing that, our goal is to be able to go through and have a measure of auditing our charts and annotating our charts as document of how we take care of our patients and know how well we are doing as a team, as a clinical team. And so that's very, very important to us being able to improve and get better in what it is that we are here to do, which is bring smiles to children and help them protect the most precious gift they have, which is their smile, make sure they have a healthy smile. And to do that, we have to make sure that it's a very, very hard job. You have to make sure that we all having all the measures that we could possibly use to always be improving on what we did today and what we did yesterday. So with that introduction, I'm going to go ahead and go through the explanation of how we plan to be using these codes for 2016. So as I mentioned, there are 6 different categories. So I will go over those broadly first. There's safety, which means the care you provide has to be safe. There's patient-centeredness, so referring to the fact that every care for every patient needs to be customized for that patient. Not everything works for every patient, so there's some measures around patient-centeredness. The care has to be effective, means that it actually works and solves the patient's problem and meets the goals that we have for actually doing the treatment. It has to be efficient, so we want to be able to get to that treatment in as convenient and as easy a way as possible with the least amount of time and effort by both patients, family, and the clinical team. It has to be timely. We have to be able to provide the right sort of treatment at the right time. And it has to be equitable. And equitable basically is the easiest one that we satisfy at Hello Smile because we are here to provide the best quality care for every child, irrespective of what their socioeconomic background is. So that's an easy one, but even for that, we came up with some codes. So now let's go ahead and we have pain codes here, which are not related to this, but entirely, but is another important measure that we're going to be looking at, which is just knowing what is the pain status of every patient, every encounter. But that is a separate video. So let's now dig a little deeper into each of these categories. So for patient safety, we're going to go through every one of these line items. We actually have 14 codes that we have come up with. I mean, there are 14 because we just looked down right here because these are the internal Hello Smile codes that we have come up with as to how we have codified each line item. And each code can have a positive or negative attribute, so or coding, let's say. So we'll start with the first one, medical history. We can be looking at any chart and make sure the medical history is updated in the chart and has a signature. The attribute to that is P, which is actually for the whole person. This is our key up here. And the code for it is safe 001, which could be again plus or minus, depending on if actually that is present for the signature or not present for that chart that we look at. Then periapical radiograph or pano image. The code for that is 002, safe 002, and that essentially is, for that tooth if it's radiograph. And that relates to when we actually do a treatment. We see that treatment is done, and we want to know if the necessary periapical radiograph or at least a pano image was present for that tooth. A lot of treatments that we do require for us to have that image, and we want to make sure that when we audit, we can see that that image was available to the clinical team. Then radiographic image for treatment. Now sometimes, anytime we do treatment, we want to make sure we document it. Now sometimes when we do dental treatment, you need to make sure you have a radiograph, especially if you're cutting on the tooth. So that could be a bite wing. So if we go ahead and see that a restoration was done, we want to make sure that the proper radiograph was actually in the chart. And if it wasn't in the chart, there's an explanation as to why. Maybe the patient wasn't cooperative for radiograph and we just did holding care. But if that was the case, then we want to make sure that that's documented such that when we were coding for that, we would not get a negative quality code. Local anesthesia note. We certainly want to make sure that anytime we give local anesthesia, that is properly noted in the chart. Minor's caries lesion charting. So if we look at the radiographs and we see that there's some small incipient lesion or small lesion, you want to make sure that's actually charted. Now we may have not decided to do a restoration for that, but we know that we can chart it as a monitor or watch lesion. So we don't want to look at the radiograph, see that there's a minor caries lesion, and that it's not charted at least for it being watched or monitored. And we're calling minor lesions as anything that's anywhere from E1 to D1, and that's E1, E2, and D1, and these are under diagnosis codes that we have gone over in a separate video. Then there's major lesions charting. Now, you see a large caries lesion on the radiograph, you want to make sure that that's actually charted. Now, you could even be monitoring a major lesion sometimes if it's arrested, but most of the time those will have to have been treatment planned. And major lesions, we're defining at Hello Smile as anything that is a D2, which is a lesion well into dentin, all the way to D4, which is basically a lesion into the pulp and or beyond. And we want to make sure that those are also properly treatment planned if you see them on the radiograph. Then there are suspicious radiographic findings. Sometimes there's just something on a radiograph that's not a caries, or there's some other thing going on that, as we can see on the radiograph, that is not charted. We want to make sure that that is properly charted. And when we do see that's properly charted, we want to make sure that we give it the positive attribute for the audit session. We have periapical radiolucency charting, progress notes in limited or palliative care. This is a really big one. A lot of times with our clinical team, we get busy and we have these patients that have limited or coming for limited or palliative care, and our notes are not so complete. So we're going to make sure that if the notes are not complete, that's the way we're coding it, such that we can know that, hey, we need to do better at assuring that we have proper documentation for these visits. Then there's our routine exams that have their own set of auto notes, and again, sometimes we get busy there as well, and we want to make sure that we both do part 1, part 2 of all of those notes, and if they're missing, again, to mark them with a negative, and if they're present, to mark them as positive when we go through the audit charts. Allergy notification alerts in the allergy section. If a patient does have allergy, we see, and it's not put on there's a alert section in the open dental chart, we want to make sure that we note that, and if it is put there, again, we will put the positive attribute for it. Current medication, you want to make sure that's documented. Prescription documentation if a patient, now this one does not always come up with audits. A lot of times it's been happening, unfortunately. A patient will have told the patient's parent that we're going to call the prescription, and something happens and we end up forgetting, and they call and the pharmacy is waiting. In a case like that, we can actually code that for that team as a negative code, just so we can say, hey, this is a way of keeping track of that particular team may be forgetting to do that. And likewise, when you do an audit chart and you see that there's prescriptions there, you can always give it a positive chart for or a positive code for it being present in the chart as we expect it to. And then there's prescription use guidelines. Now, there are times we may see that a prescription is written and we want to see, based on the documentation and the radiograph, a prescription was warranted for the patient, and make sure that we're actually appropriately prescribing medication. So those are all safety codes that we're using. Now we can talk about patient-centered codes. Patient-centered codes, one of the first ones is treatment authorization. If you want to make sure the treatment that we're doing for the patient is actually authorized, so if it's not authorized, then it's a negative code, and if it was authorized, it's a positive code. Of course, we know a lot of the treatments don't need pre-authorization, but we have to make sure, based on the history of the patient, which we can look up on the dental history image, that has not already been built out and or done, and that you're not embarking on doing it without assuring that we have proper authorization from the parents, such that they know they would be responsible for it. Check out accuracy. You want to make sure that anything that's checked out is actually accurate, of course. We don't want to say that treatment that wasn't completed is actually completed, and that can sometimes easily happen by just putting the wrong clicks followed by the checkout click. Charting accuracy. You want to make sure that what's actually showing up on the panel radiograph or other x-rays is showing up on the dental chart. Behavior note documentation, very important that we're actually making sure all the behavior notes are there. New appointment treatment planning. Next appointment treatment planning. So this is a really, really important one. We want to make sure that we can see that the next appointment was given to the patient with an appropriate treatment plan. Next appointment made. So one thing is actually treatment planning of the appointment. The other one's actually seeing that the appointment was made. Now, this is a little bit less related to the clinical team, but nevertheless, it's part of clinical team's effort and emphasis to make sure that the appointment is made by the front desk team. Justification for exfoliating tooth extraction. So a lot of times parents come and they just want to take a tooth that's sort of falling out by itself out by our doctor, and the doctor has to really evaluate and see, okay, does he or she really need to do that? And there's got to be proper justification for that. Is it for an infection, or is it because patient can't now do proper oral hygiene and have localized gingivitis, or is it that it's ectopic, causing ectopic eruption of the permanent tooth, or that the patient can't eat and they're in pain? Anyways, it needs to be documented. And again, all the different reasons that I mentioned are all different diagnoses that are part of our diagnosis codes that can just be simply attached to that extraction. But they do need to be attached to the extraction for that type of extraction when the tooth would otherwise be falling out. Needed space maintainer treatment planning. In the new year, we hope to make sure that we're not missing space maintenance therapy. If a patient has had an extraction or is missing some teeth and that space can be lost, you want to make sure that we're properly treatment planning space maintenance. Referrals, we want to make sure that patients are properly referred to ortho, oral surgery, endo, general practice. Prognosis codes, we want to make sure prognosis codes are actually included when we expect them to be there, specifically for that patient. This kind of relates a little bit back to the prognosis codes for the exams, but in general, we want to make sure that anytime we do any kind of treatment, the proper prognosis codes are actually there. Diagnosis codes, actually, I take that back. Prognosis codes here is different than progress codes. So prognosis codes is what we talked about at a different video, where we actually say what is the prognosis for the patient, for the treatment that we provided for the patient's diagnosis. So for example, let's say if the patient has low caries risk and they are just coming for recare, their prognosis is excellent. Whereas a patient that has high caries risk and they're coming with lots of dental disease, lots of decay, and their parents are just not bringing them in every 6 months or every 3 months, and we're not helping them with brushing and diet, then they would have poor prognosis codes. So we want to make sure that we're putting in the prognosis codes. So sorry about that confusion. That's not progress code, but prognosis code. Diagnosis code are the use of actual diagnosis codes for when we treatment plan for what it is that we plan to do for the patient. So anytime we actually treatment plan an extraction, restoration, space maintenance, we need to make sure that we actually use the proper diagnosis code. And again, we've gone through diagnosis codes with a different video for our clinical team, such that they're familiar and know how to pick diagnosis codes for every treatment plan that they propose for each tooth. Caries risk assessment status. That's kind of sort of like diagnosis codes, but it's very specific to caries risk. We want to make sure that every patient that comes through Hello Smile actually has their caries risk assessed and has assigned a either low, medium, or high caries risk assessment. It's very important. It's present in every chart. Key diagnosis based on radiographic images. When we go and look at a chart and we see that maybe there was impacted canines and there are no notes made about the impacted canines, that's a key diagnosis that should be made. And conversely, of course, when we see that the canines are circled and recognized, or let's say missing teeth are circled and recognized, that is when the key diagnosis has actually been made for that case, and we want to code that as plus or minus as such. 1 to 3 month treatment planning. This is our 1 to 3 month recare. For the high risk patients, we want to make sure that that's actually being treatment planned and that you're coding for that, and that's really big part of our patient-centered push for 2016. Infant dental visit. That's really not relevant here. We've just included it such that we can just track to see how many infant dental visits are we doing. And same thing with our semi-annual 6 month recare visits. These two actually don't really apply to the clinical team so much. It's more of our own tracking codes. Then we have treatment effectiveness, and we have 3 codes for treatment effectiveness. One is restoration longevity. Basically, the restoration longevity refers to, okay, hey, did this treatment last or did it not last or fail? And we expect for treatment to last for at least a year when we provide that at Hello Smile. And if it's failed prior to that, then that's a negative score. Now, if you just take in a general look at a chart and we see that it's lasted more than a year, then it gets a positive score. Sealant treatment done. We want to make sure that sealants are always done, and that's part of the effectiveness of our treatment. When we provide sealants, we really save a tooth from getting cavity and in the future potentially having root canal. And you want to make sure that sealants are actually done. You look and see, hey, does this patient has 6-year molars, 12-year molars, and are the sealants treated or not? And then the sealant treatment planning. So one thing is actually the sealants being done, and the other one's like, okay, maybe they didn't get done, but we look and see that either 6-year molars or 12-year molars are present. They didn't do them, but they have treatment plan for them, and so that's a different quality code. We also do have a whole set of codes that are for that are already in the Woodside database that are all of our redos. We're not rolling out these codes yet, but they will be rolled out in the next phase of these codes when we actually have to redo any sort of a treatment. Okay, with that, we're going to go on to codes that we are using for efficiency. So for efficiency, treatment efficiency for patients. So here, for this code, we're looking at opportunity to provide maximal optimal needed treatment per patient behavior and scheduling time allowance. You basically look and see, how much treatment does the patient need? Do they just need, 4 sealants and maybe 1 DO? And if the patient's behavior was good, was all of that treatment completed, or was it not completed? Or was it only 1 tooth or 2 teeth that were completed? And you have to take into consideration, what was the timing allowance, of course, in the schedule, how busy that hour was, how many patients had to be seen. You also have to look and see how was the patient's behavior. And one thing that we don't have in here right now, you also have to look in for staffing and see, hey, were we properly staffed for this to be efficient? But nevertheless, we want to go and measure and see how efficient are we being by looking at all of those parameters. Treatment efficiency for schedule. So this is another related one. Sometimes, we have open slots in the schedule. So you may treatment plan something, and the opportunity to provide the needed treatment on the same day of the evaluation or exam is missed, even though, let's say, in the next hour we had cancellations. and the patient that just had the exam and could have just stayed and been having and would have had their treatment completed has now left and is have to come back, which provides for inefficiency in care when we could have just had them wait and have the treatment done. So anytime you suspect that the day is not going to be so booked and you see a patient and you treatment plan them for treatment, you want to make sure that you don't miss the opportunity to provide the treatment on the same day if you're going to have the open slots in the next hour. Space maintenance treatment planning. This is also under SAFE. We've talked about that already, but basically we're talking about just treatment planning of space maintenance. Then there's space maintainers same day. Now, there are also opportunities to provide space maintenance on the same day, and for providers and teams that are able to do that, that's a really good positive mark because, again, you're making the treatment that much more efficient, whether it be by use of the chair side band and loop space maintainers, or even taking impression and fitting bands right before the extraction, such that you reduce one visit for the patient for their space maintenance. SSE size is another important efficiency note. We want to make sure that when we do SSEs, we note the size in the chart. We're not really going to be looking at that in the first quarter, but something that we just have here. Quadrant care, we're not going to be looking at that either in this quarter. And behavior node treatment disharmony. This one we're basically talking about the fact that if the patient's behavior is plus, then whatever treatment that they have, we want to make sure that, again, we're maximizing on treatment. It's basically very, very similar to treatment efficiency for patient, which is, basically this line item here. This actually will get combined with 186. 182 will get combined with 186, but the idea is the same. The next category is timely. So there are all sorts of timeliness related to the care that we provide. And we have 7 different types of timeliness that we have defined. So we're not going to be really focusing on this one that much, besides the very first one, which is a patient wait time beyond 15 minutes from the scheduled time. We want to see, how are we doing in being able to actually see a patient on time when they're actually scheduled to see us. And we'll get into other timely measures in the future quarters. The last one is equitable, and we'll just briefly talk about that. So the nitrous oxide fee can be waived, and we can look and make sure that we're not ever turning any patient away because they need nitrous oxide and they cannot afford our modest nitrous oxide fee, and or a patient that needs the 1 to 3 month recare treatment regimen, and that for some reason they cannot afford the modest fees for that, and we want to make sure that we're not turning them away. We're still working on seeing how it is that we're going to be actually really measuring these ones, but we just put it there as ways of looking to see how we're going to measure our quality around those. Less favorable treatment is making sure that we're not ever doing a less favorable treatment simply because a patient cannot afford the better treatment. So again, these are a little bit less applicable, but we just want to make sure that we have our eyes on them. So with that summarizes how we're looking at quality based on the Institute of Medicine 6 measures of clinical quality of care in the context of pediatric dentistry. And we'll be working with our compliance team and clinical team in seeing how we're going to go about coding our performance and how we're going to be monitoring our performance such that we can get better every day.